In the audience, we have some of the community's best leaders. We've got folks that have been doing great things for the community. How have your medical schools and institutions partnered with the community to date? And how can we do a better job as a community partnering with academic medicine moving forward?
Well, I'll start. So our curriculum has been deeply community-based right from the beginning. We recognized that we wanted our students to be really embedded in the community. That's the other way we think we'll keep them here. First of all, I should have probably said we only even interviewed students who were from Nevada. We had 900 applicants and 400 of them were Nevada residents or with deep Nevada ties. So that's the first step in getting them to stay here. The second step is really getting them to understand the community. So they're starting out becoming EMTs, and during that experience they're going to get public health. And we've identified 10 zip codes that have the lowest health outcomes in the city. Then 6 students each are going to look for the things in the communities that affect health. So they're going to start with that. They're going to do 2 hours a week in a community agency. We have lined up 80 community agencies in our city that they can select from. We've used those community agency people to interview our students as well. So each student being interviewed for admission has 1 community member and 1 faculty member doing their interview, and it's a structured interview with 50 questions that are up on the web. So, and they've been trained to be able to grade them. So we're partnering all along. We've also identified 5 kinds of community issues that we think are the most important to have threaded throughout the curriculum. And those are, the first is nutrition and obesity. One is mental health and addiction. One is human trafficking. I don't know if I can remember all the rest of them, but they're major community issues, and we think that doing that will, again, the students will continuously throughout the 4 years be thinking about those issues. We also then have our 3rd year curriculum is different from most other medical schools in that we're doing an outpatient curriculum. So the students will spend their whole 3rd year in an outpatient setting with one group of patients that they'll follow the whole year. And we think that, again, will be a piece that'll really tie them tightly to the community that they're actually practicing in for that year. They'll do their hospital work in the 4th year. Most schools do the hospital work in the 3rd year and do electives as outpatients later on. So we think each of those is going to help with that community tie, but we're very deeply community tied.
Thank you, Dr. Atkinson. Dr. Alden, Dr. Penn, you're private institutions. You don't have a lot of the support that Dr. Atkinson has from the state. How can the community best support you?
Well, ironically, we had our gala last weekend, and it was standing room only in the Four Seasons, so they can help by attending things like that. But that's a little facetious. I think the issue is we really always are looking at collaborative opportunities, not just handouts. We're looking for scholarship opportunities for our students, for the children in the autism clinic, and we believe in social justice. It's part of the mission of Touro University system is social justice, and that is getting out into the underserved communities and having our students really apply what they learn in the classroom or in the laboratories. And that's not to the exclusion of being in a hospital and the various specialties. It's in addition to that. So we have people going out on our mobile clinics routinely, to Shade Tree, to various other philanthropic groups throughout town that that serve the underserved population. Opportunity Village, we're having discussions with a number of other groups. Matter of fact, next week we're having a groundbreaking. The Southern Nevada Health District is setting up a facility on our campus. So we really believe in getting the students out in the community as part of their educational experience, starting with service learning during the first 2 years and then going out and actually practicing during the 3rd and 4th year.
I guess I had two questions. Do you have to do anything special for academics for the telemedicine component? Because that was legislation that was passed last session. And then secondarily, what's the impact if the repeal of the ACA comes into play?
That's a loaded question.
Thank you for that.
It's probably more directed to me.
How about, I'd be happy to answer the first question.
Oh, sure. And I've been asked almost every 30 minutes on that since Monday, so I'll do my best on what we're doing.
Telemedicine is extremely important and going to be more and more important in the future. It really works for a lot of different things. It works particularly well in the psychiatry realm of child and adolescent psychiatry and regular psychiatry. It's really good in follow-ups of surgery and things like that for people in rural centers. It's good for cancer, not for the initial diagnosis, but after a diagnosis is made for treatment follow-up. And it doesn't just have to be rural. It can really be useful urban settings as well. And we're now exploring setting up a program with UMC that's really interested in setting up telemedicine as well. We're interested in working with community health workers who can go out to somebody's house and actually be them there with the patient and help them with the technology that's available. But you can do it now by distance and with just a computer on the spot. You can take it to homeless people in parks and things like that. So we're definitely working on the telemedicine piece, and I'll leave the ACA piece to Ms.
I'll only handle the telemedicine too. We have telemedicine in our mobile clinics for a reason that may not be initially obvious, but with the Opportunity Village populations, you have caregivers, and the caregivers often can't come in with the patients, and telemedicine allows collaborative visits together so that the caregivers and the patient can interact with the provider in real time and understand exactly what's being discussed. We also have a very much of a presence in things like physical therapy and occupational therapy, which people tend to think of, rightly so, as hands-on things. But if you've been in physical therapy for a while, if you've received physical therapy, about 75% of the visit is making sure you're doing the exercises correctly. A significant portion of occupational therapy is making sure that the home is set up properly so that slip and fall and access to daily living is routinely available, and that is also available through telemedicine. So I think telemedicine is going to change a lot of access in healthcare throughout the country, but hopefully here in Nevada as well.
The one thing I would add to this is that when I was in practice in Ohio, I was in a rural community, so I was pretty much isolated, and so you had to do things without having x-ray at hand and other kinds of things, so you had to learn how to talk to people, and you had to learn how to take good care of them from a physical exam standpoint. That's one of the critical features. We still need to teach those things for our students, but when we are talking about sometimes even the inner cities, but here it's very different than in Ohio. The rural communities are not frontier. It's frontier here, obviously. It's a lot further distances. But one of the lessons learned that we're going to be, of course, helping with is we're trying to figure out how do we help the practitioners that go out into those frontier medicines, let's say locations, and part of that is this telemedicine is going to be very helpful to them, because when I was in practice, I didn't have a partner that was always next to me, always giving me advice or talking to and so forth, and having all these kind of technologies that are available today. So this is really, really moving us in the right direction, but we need to help those that are out there in the frontier trying to do the hard work, and we need to find all kinds of ways to support them.
This is called passing the buck down to Mason.
Yeah. And I do see we have a line for more questions, but we obviously very concerned about, regardless of your political affiliation, the outcome of the election. I immediately met with my team the next morning and knew that healthcare was going to change. So the hospital's done a really good job of positioning itself over the last couple of years for whatever scenario comes out of this. But again, I can personally tell you, and just not UMC, this is every hospital in the entire state, in the entire country, we've seen benefits of having more patients covered, insured with healthcare insurance. I could tell you my emergency department volume is down significantly. And, as an operator of a hospital, typically you get concerned, but for me, that's a good thing because it tells me patients are getting care in the right setting. They're getting the medications they need. They're getting a primary care physician that they had never had before. Again, they're getting care in more less costly setting, a more appropriate setting. So again, obviously our governor chose to expand Medicaid. I've talked to pretty much every legislator, including the lieutenant governor this morning, about they're calling us, what are our concerns? So they are actively listening, and I think we're all aligned as an industry to say, this actually had some good benefits for patients. Again, we are positioned at the hospital. If you look at our success and you reference the Good Government Award, about a third of our success was related to the ACA, but the rest of it was really about containing our costs, looking at growing business, elective business, and re-engaging our physicians, investing in technology. But I know many of you are business and community leaders in the room, but if you look at pre-ACA, about 40% of our patients did not have insurance coverage. If you've ever been to the hospital lately, you may get some sticker shock because it's very expensive because you're not only getting a hospital bill, you're getting a physician bill, a radiologist, pathologist. So post the ACA, our uninsured amount percentages have gone down to about 12%. That remaining 12% are the patients that chose just not to participate in the ACA and take the penalty. And then also we still have an undocumented problem where they won't qualify for any type of coverage. So just not UMC, all the hospitals are really aligned on ensuring that we have some type of coverage. I'm personally concerned about taking away some of the mandates or at least some of the insurance minimums. These deductibles nowadays are $5,000, $10,000, and really what you're seeing is patients delaying their care. They're choosing not to get their preventative care or their mammograms or other things, and they're showing up in the hospitals much sicker, much more acute, which certainly drives up the cost for all of us. So again, we'll continue to see what happens. I just hope that they don't rush things. We're already making decisions on Wednesday and Thursday. They need to take their time to make sure we get this right.
First, I'd like to compliment the three medical schools. You are working together and you're not competing, and you're doing it for the community, and I've had a chance to work with you, and I'm so impressed by the collaborative attitude. So congratulations. The University of Nevada, Reno does a study every year on doctors per 10,000 in population, and Las Vegas meets the national standard for anesthesiologists and plastic surgeons.
That's all. That's it.
All the other specialties, we are below and often woefully below the national standard. So I am very concerned about the success of your residency programs, because you can educate a lot of doctors, but if we can't get them to come here and stick, we're not going to have doctors. And I have learned that the residencies are sort of a computer-generated match that occurs on one day all over the country, and the school and the community has to market itself to these prospects to get the best and the brightest. And I'm curious how you think you will be able to market Las Vegas as an attractive place for prospective physicians in our residencies, and if there's others in the community or people who could probably help you with that marketing challenge.
Well, I think everybody knows that there's always a challenge with the image problem of Las Vegas, and the typical non-Las Vegan just doesn't have a clue as the quality of life here is very, very good. I think that's the challenge, is that, this is a good place for residents to come, for physicians to live and raise their families, and I think that requires a community-wide strategy on how do we also sell this idea that this is a living community, a very high-quality community, and not just what stays in Las Vegas stays here.
Yeah. And I'll say that we've not had any trouble recruiting faculty, which has surprised me because I was told that we could potentially have a big problem. But people come because the place is what they want to be part of. So, and it's the same for residencies. If we can have really good residencies, really make sure that they're high-quality residencies with high-quality teachers and clinicians teaching them, they'll come because they'll come for the program. But we do have to overcome that image. There's no doubt. We have to show people that we like living here and show them the rest of the community. And we do have realtors that take people around and show them that there's more than the Strip. That's probably maybe the most important selling piece for the families. And the education is an issue that it's an issue not so much for faculty because they may be able to afford a private school or a charter school or something like that, but it will be for residents and people who don't have the higher incomes at that point in their life. So it is something that we are going to need to have help with.
And then having the 3 medical schools and having students be here for 4 years at a minimum, some are here for their lives, they know differently. So I think having the slots available to our students so that they don't find a more attractive residency slot somewhere else.
And, to add to the education comment, this past biennial budget that the governor and the state legislators focused on K through 12 education is one major step to helping improve things here, and so it's something that we need to champion. We're not where we need to be, as we know, but that's probably one of the major reasons why some people don't want to come here. The other, as many of you know, is that people want to go where there's good health care, and that we're right on the beginning edge of that. The other point I would mention, when I go around and talk to people about why do people choose medical schools, it's kind of like, why do you choose residency? In the top 10, one of the most major ones is location. This is a great location, by the way, when you look across the country at a variety of reasons that we've already mentioned here. But they also will choose coming to our programs because they like the curriculum. We all 3 have different ways of looking at our educational models, our delivery of our curricula. So we're going to draw different people, and that's fine. And that's why that's exciting. We will, there will be some friendly competition, the way that I would put it, because people are going to basically say, well, maybe I'll go to UNLV because I love what Dr. Atkinson is saying and so forth. The point is, it's also about the faculty that we bring. And so it's incumbent upon us as deans and administrators at these levels to make sure that we are recruiting the right kinds of people to represent us in this community. Because what it does then, it's like brings other people to you that are also of high quality into our community. And it makes a real huge difference because of the collaborative efforts that we're trying to do.
Well, I have to tell you that I've learned a great deal about all of the various programs that are going on today, and it does thrill my heart to know that so many wonderful programs are going on. But I have to tell you, I also feel very isolated. I'm Councilwoman Anita Wood. I represent the city of North Las Vegas. I sit here with tears in my eyes, truly, as I listen to the fact that the health district is putting in a new health clinic in Henderson at the Touro University. I think it's wonderful. The health district closed the clinic in North Las Vegas over 2 years ago. I can't get them to discuss with me any kind of permanent plan to replace our clinic. As I sit here and listen to Roseman University opening up its new clinic in Summerlin, and UNLV right in downtown heart of Las Vegas. So what do the residents and citizens and city of North Las Vegas need to do to remind the medical community that we are here too?
Let me just make a few initial comments. Thank you for those comments, because I know that it feels for some of you that when we say where we are, that's where we are. When you're building a medical school, especially, I'm speaking for Roseman right now, we're so early in this process, but we're building what you call a community-based medical school that's relevant to the entire Southern Nevada region. We have reached out to the mayor of North Las Vegas. I've met with him twice. I've gone to the other mayors. I've talked to them. The first thing that we must do is understand our communities, getting to your points. So once we understand, then we can start to say, how do we then serve best? I have posed the question, how can we get into North Las Vegas? Where is it best for us to do so? So what I would tell you is, getting to one of Dr. Atkinson's point about where we are in this process, we have to get off the ground first. But my plan, and it's not real long from now, but my plan is to have clinics and other kind of things throughout this Southern Nevada, which would include North Las Vegas, just as an FYI. But it just takes time to get us off the ground. That's what's happening with UNLV. We'll be following in another year or two. Toro has been here, and they've done a substantial work here. But I would just assure you that you're going to see more and more happen, not only in North Las Vegas, but across the Southern Nevada region.
I'd like to clarify something. The Southern Nevada Health District facility in our clinic is something that moved from the city of Henderson down probably within 5 miles of where they were. It saved that organization $600,000 a year. So that was not an either or. It was we worked with them to help save them resources they could have spent elsewhere as well. But we do have spoken a number of times with the mayor of North Las Vegas. We've discussed building areas around the VA hospital that we're very active in, and we are actively engaged in discussions with a group that has facilities in North Las Vegas, and we hope that that will help us provide a presence there, just like we have a presence wherever our mobile clinics go.
And just, oh, I'm sorry, Dean, go ahead.
Well, I was going to say that we're sort of in the same situation. I've promised to you and to the mayor that our next big clinic for our students will be in North Las Vegas. That is the biggest need. We took over the practice now that is in the medical district, so we're putting our first 60 students there. Once we get a medical education building built, which is probably about 4 years from now, we'll asked to expand our class to 120, and I've promised that that clinic will be in North Las Vegas. So,
Mason, I'm sorry. Mason, if you want to give a few words, we're going to have to bring this to closure.
No, Councilwoman, I appreciate it. I may get the evil eye over here from my boss, but I think I've got her support. But one of the things in my tenure is I firmly believe I'd like to see more than just one hospital at UMC. I think we've got a great brand, care second to none. So I know that we've talked to folks in the city of North Las Vegas on their request for additional hospital beds. And again, I think it's something I would like to see, a smaller UMC North or UMC South, but we have been looking at that. So again, if I can get some support here, and I know I do, we would like to have a presence in North Las Vegas as well.